a normal, healthy life. But more often than not, that cannot be satisfied. So they have their own expectations, their own feelings, and uh, most of these individuals have had a past medical history, in the sense that they've been to multiple doctors, or people have not been able to diagnose them, so they've been through a long medical odyssey that they come with. So we have to understand and keep that in mind as well, that when they come to us, they want like quick results sometimes. And that can lead to anger, frustration, confusion, feeling of helplessness, and things like that, and strong emotions like that. Then comes the issues that might arise from the system. Although this does not happen very often in India, what I mean to say that system originating factors could be, um, like there's less follow up from patients. uh, a lot of times we don't have like genetic counselors. If they have a lot of families to see in one day, they might not have the bandwidth, or they cannot cater to every family's needs in detail. So that could be system related. And from the genetic counselor's perspective, the challenges that might come, we will discuss in detail about this at the end of the session as well. But an individual's own feelings, or their own triggers can leak into their work, and that the same thing can happen in a genetic counseling session as well. So these are a few factors. But besides this, what might lead to a challenging interaction with the patient could be when we deliver bad news to them. um, they don't want to continue, or the family does not want to continue the medical care, so there's non-compliance. uh, a lot of times people have stigma associated with genetic testing, and helplessness or confusion. And a lot of this arises because genetic diseases and genetic diagnosis have impact that go beyond an individual. So of course, yes, if an individual is affected, uh, the disorder might be debilitating. It might impact their day-to-day life. It might also impact their, like, it might have a long-term impact, but also it has an impact on their family. There's something called the carer's burden, meaning that the people who have to take care of a affected individual have their own burden as well. But besides that, it might also reveal things about people who are at risk, family members, and you have to counsel them in the same way, in an empathetic way. All these situations put together can lead to a challenging interaction, which then leads to strong emotions or difficult emotions that might come up. And we have, as genetic counselors, we have to differentiate between what a reaction is and what a response is. So, and I think this is something that we can apply in our day-to-day life as well. um, Response is always thoughtful. You have thought about it, you have deliberated about it, and you've understood that, okay, this is what has happened with me, and this is the plan of action. It's a very conscious decision making process that you go through. And so if there is a conflict, it might de-escalate the conflict. But a reaction is an automatic behavior, it is an impulsive behavior. Your subconscious emotions come into play, your thoughts and fears, insecurities, all of those come into play, and that's when a reaction forms. So you are on autopilot mode, and this is what escalates conflicts. And that is why the title of this talk is Managing Patient Reactions, because more often than not, they're not, when you break bad news, or when you deliver a report, patients do not have, or families do not have time to think about how they feel about these things. They just have a lot of questions to be answered, a lot of reactions come out. With that, we move on to some key principles of what these strong emotions mean. um, what to do, what to think about these strong emotions. So, firstly, strong emotions are very normal, and they are very predictable as well. in further slides, we'll understand how we can see anger building up or what are the signs that we should be aware of. And we need, as genetic counselors, we also need to understand that these things, these emotions are very normal. If someone were to get a decision about their life that may or may not change, this is something that we should be prepared for. And responding to this will only strengthen the clinical alliance or the therapeutic alliance that we have with our families. And of course, we do not need to fix them, we do not need to tell them to, you know, we need to validate their emotions. So we need to give them an empathetic response, and that is when they will feel empowered and strengthened to go through the entire medical odyssey. So the various emotions that we might come across in our practice is dissatisfaction, disappointment, anger, frustration, worry, hopelessness, uncertainty, vulnerability, grief, distrust. And all of these emotions originate in the experience or the anticipation of a loss. So, the loss of an individual or the loss of your body function, because you might in future become dependent on other people to take care of you, or even if you're not able to understand the situation, all this uncertainty and the anticipation of loss or the anticipation of something going wrong can lead to all of these emotions and a lot of these emotions. So, with that, entering our first emotion, which we come across very often, is anxiety. And again, anxiety is a very daily daily experienced emotion. Like even I, as an individual, can have feeling of anxiety on a daily, on one of the days as well. Now, how do we differentiate anxiety that can be difficult to manage or easy to manage? What people might feel on a day-to-day basis, or more often than not, is of a lesser intensity. When you go through a really difficult period of time, that can be what I'm trying to say is that anxiety is a spectrum. It can be mild to severe, and then it has further stages of depression and so on and so forth. So, why might anxiety arise? Is because of the potential outcomes of genetic testing, the risk of developing or passing the genetic condition, and the impact of their future health or the family members' health. So, what are the cues that we are going to see in the patient or the individual? We will see that they're very confused, they're not able to put their questions into words, and therefore they have difficulty in expressing themselves. And when we ask them questions about whatever difficult questions, maybe about their extended family, maybe about their parents sometimes, or if we ask parents about their children, they might not immediately answer. They might have a sense of withdrawal. That, and also a very visual expression of anxiety is, if people are just tapping their foot or they're fidgeting with their fingers, if they break eye contact, these are non-verbal cues of anxiety or nervousness or even uncertainty. And if they are explicitly telling you that they're just feeling that everything is going wrong, nothing is going right, then that is also an expression of anxiety. Now, how, as genetic counselors, how can we help them? We can ask them a few questions, like how we ask a child. We can ask them what is making them anxious or what is making them fear this, what are their insecurities, and we can help them put these things into words. And that is one way. Another way is to also explain the situation in detail, saying that, okay, this is the genetic test that we are offering. You can choose to not go for it, but if you don't choose to go for it, these are the things you will be missing, and this will be the advantage. Similarly, if you are, opting for the genetic test, these are the benefits and these are the limitations. Are you ready for it? This is what your life might look like. with the diagnosis or without the diagnosis. And when you explain them these situations, you can see that the clouds in front of their eyes or in their mind are just going away. So you will understand that there are a lot of questions that they are not able to frame but are feeling, and that is being expressed as anxiety, and you have cleared those questions. So another strength of the genetic counselor should be anticipating these questions. And above all, we have to acknowledge the uncertainties, as I mentioned, while being honest. So it's you have to assess if this individual requires a little bit of sugar coating, or if they want you to be brutally honest. That is up to you. I would also like to mention that if there are any questions or any interactions with patients that you would like to share, please feel free to pause me. I would love that. Then another emotion we come across is fear, and very similar to anxiety, this has very like visual cues as well. So you will have furrowed brows or a tense forehead, and you will also have repetitive questions because they're seeking validation, they're seeking reassurance regarding their fear and their uncertainty. And when you ask them questions, this is a very, very good pointer, which is that they will get defensive to your questions or suggestions. And, there was a family where I was very clear and I was telling them that, you can opt or not to go ahead for testing. And that is where they were like, no, no, I will only go ahead for testing if I want to, which is the same thing that I said. So that is when I picked up that there are some anxious molecules and some fearful emotions that are there within them as well, because they repeat the same thing that you are saying but in a very defensive manner, and they react that way. So that is one flag. Now, how as genetic counselors can we respond to this? We have to listen to them because number one, they're already defensive, so we need to create a very non-judgmental space for them where we have to make them feel that they are the ones who are in control. And very similar to how we would react in anxiety, we have to clear their questions, clear their uncertainties. We have to give them some supportive resources that will help them clear these questions as well. Another common emotion is guilt, and a lot of this comes out in the way that they have negative self-talk. They keep saying that this is what has happened because of me. And Recently, as an example to this, one of the families that we were counseling, he was diagnosed with Lynch syndrome, and he came for follow-up, and he mentioned that he had a divorce and a fallout with his wife, and he had a lot of self-talk, a lot of a blame to himself. And that was quite surprising because in the previous sessions he was putting the blame onto someone else. He had a family history of colon cancer. His sister had colon cancer, his mother had colon cancer. And all this said, suddenly when his wife left him and he had a diagnosis of Lynch syndrome, that hereditary cancer syndrome, um, he blamed himself, and there was a lot of guilt within himself instead of blaming it on others. So that negative self-talk and seeking forgiveness for his actions, whereas things are just not in an individual's control, that is when you can say that a lot of guilt is coming forward, coming into the picture. Now, how as genetic counselors can we respond to this? um, we have to encourage open communication about this. We have to understand why they are thinking this way, and we have to normalize these things. We actually, a lot of patients seek comfort in the fact that there are other families like them, or there are other individuals who have had more severe diagnosis. It Not always, but sometimes it does help them that you validate and normalize these things. Now we also, in tough situations like guilt and sadness, we also have to understand that sadness can easily just slide into depression or slide into a chronic anxiety state. And so for that, we have to ask them about their support system. We can ask them to bring whoever they feel is their support system for the counseling sessions. We have to reframe these perspectives, because the more they choose the neural pathway towards being sad, towards being the victim, and towards them to just go and slide into the spiral of depression. So we have to rephrase that negative self-talk into how they can help themselves and how they can heal from um, this difficult situation of having a chronic diagnosis. And on another subtler emotion is the confusion. When people come from the rural background or people who are not educated, confusion can lead to a very severe state of confusion. And that is very difficult, because the moment you go into that, there is the cascade of emotions that can begin. So for confusion, the cues that we can identify is impaired decision making. This might also lead to frustration, this might lead to fear, anxiety. And when you're not able to make a decision, you also go into the fact of self doubt and guilt. These are other emotions that can come up. And something again, a visual expression of confusion could be disorientation. There is visibly the patient or the family, when an easy thing to do is that you ask for certain reports. So if you say that, can you please share your ultrasound reports, or can you give me your MRI reports, you will see them just going through their reports in a very haphazard way, and they're very scared. So you can calm them down and you can tell them that it's okay, we are here to help you, be supportive of the situation. And we when we're also taking history from their end or asking for information, as I had said, they might also modify it. A lot of times what happens is, as junior genetic counselors, when we take the history and make the pedigree and write the history of presenting illness in a structured and chronological manner, when we take the family to the senior genetic counselor for counseling, they change the history, or there is a new thing that has been added to the history, which could significantly change things. So now that can be because of many reasons, but one of the reasons is confusion as well, and a visible lack of focus and attention. Now, how can we respond to this as genetic counselors? We can use visual aids. We can engage family members. We have to be very concise, and this is in relation to the visual aids and asking questions as well. So you can ask open-ended questions, and if they're not understanding you, in our hospital we have pictures which are like for chromosomes and for amniocentesis, for CVS. We have images to explain what exactly is going to happen. So with that, we can give them a clearer picture, and we can help them in the decision making and answer a lot of their questions just with the visual aids as well. Now, one of the dangerous emotions, which is a red flag, is the anger. Now, anger can arise because people are very people don't want to be in this difficult situation. They want to get out of this sadness, out of the situation of going through a medical disorder or having a family member with this medical disorder. And more often than not, it is involved, and it includes um, frustration. So, what do we recognize in the patient? We can see that there is verbal aggression, physical aggression, and they are again getting very defensive, and they also have a lot of complaints. So, they will go on to talk about how their previous doctors have not helped them, nobody is able to diagnose, and things like that. And when you offer any counseling to them, they might cut you in between, because they feel that what they are trying to say is more important, number one, and also that we are not understanding their situation. So in this uh, situation, what I usually do is, and why we need to understand how to at least manage anger, is because in India, multiple family members can come for the counseling. So they are in majority and you are a minority. And also, a lot of times you can be intimidated by the family members, and that is completely okay as a genetic counselor. It's fine. With experience, you will understand how you can take control of the situation, um, and in another way, you yourself have to be calm, you have to be composed. I would say that like I will never raise my voice even if the family members or the patient has raised their voice. So you have to listen to their concerns and you have to address that. uh, we will explain everything to you in detail. They might be upset on different things. They might be upset as to there is a long waiting time, or again, in the past they have met a lot of doctors and they haven't gotten a diagnosis. There's no treatment, and it might also be so that multiple members of the family are affected. So they are very there's a lot of unresolved anger within the family as a shared emotion with all of them. So in this situation, we have to avoid taking it personally. We have to be calm and we have to explain everything in detail to them, no matter how long it takes. This family needs your attention. Anybody who is going through anger, whether it be an individual, a couple, or family, you have to give them your attention, because if you don't give it in the very first session, it keeps getting piled up and it will come out in further sessions. It might also result in them not following up as well. So you offer them choices and the different options that they have, so that they feel that they are in control. And secondly, if things are going out of hand, you have to set clear boundaries, because safety is very important. And once the session is over, you can give a hint to the family or individual or couple that you have to reflect on how you have reacted, or you have to reflect on what this situation means for you. And as genetic counselors, we have to do a bit of personal reflection as well. Well, the next emotions are grief and bereavement, again, very commonly seen in the genetic counseling setup. Grief is a short term sadness at a very deep intensity, or at a very severe intensity. And what grief translates to, it can be for many reasons. It can be that your dog died, or your partner broke up with you, or you lost a family member. Grief can have multiple reasons. But on the other hand, bereavement specifically means the grief that you feel due to the loss of a loved one, when there is death involved. So that is when you bereave. And grief is, it could be multiple reasons. You don't have to have someone who has died if you have to feel grief. Now, we all know about the 5 stages of grief and the various stages that are included. Number one being denial, anger, depression, bargaining, and acceptance. So, denial is when you're not ready to um, even accept or acknowledge that there is something that is not making you happy, that is making you really, really sad. And then you get angry of why you have to be in the situation. That's all. Simply, you don't want to be in it. You want to get out of it. But when you are chronically in that situation, and when you're not reflecting, you're not understanding the origin of it and processing it, that in a chronic way leads to depression. Now, depression can be for a few days to months to years, um, but in this situation, it could be in any degree as well. And then you bargain. Your bargaining means, what if these things could have been different? What if my child was not affected? What if my parents did not have cancer? These things. And finally, you lead to acceptance. And acceptance means that, okay, in one way or another, you have made peace with your situation. So what usually we think, or what usually textbooks make us think, is that this is a linear process. That you will have denial followed by anger. Very nicely, depression will come next, and then bargaining and so on and so forth. But that is not the way this happens. What actually happens is everything happens together, and everything also does not happen together. So in one way or another, depression might come first, bargaining might come last, anger might come in between, and there's really no way of what to expect when you are grieving or bereaving. This is not a linear process. Many individuals could be experiencing one or two of these emotions simultaneously. And to differentiate, I think you might be a little confused of between grief and depression, or anxiety and depression as well. But the lines between all these are very blurred. So just to differentiate a little bit, grief is the longing for a previous reality that used to exist. So that's what I said, that if you've lost a pet, or if you've lost a partner, if you have gotten less marks in your exam, that all of it could be your previous reality or your anticipated reality, which you did not get, so you would be grieving that. But depression is a long term, uninterrupted feeling of apathy. It is very static, you feel withdrawn, and individuals do not feel the like they do not have an intention to feel pleasure. And how, as genetic counselors, can we support this? We can assess if the patient is ready to discuss genetics first of all. Are are they even ready to talk about their diagnosis? Are they even ready to hear about the options of testing and things like that? We have to give them a safe, non-judgmental space for their expression. We have to educate them about the grieving process. People might not realize that they are going through this process. And finally, as I had previously mentioned, we have to ask them about their support system, and we have to help them, rephrase negative self talk. We have to help them come out of that grieving process in a way that they have also processed everything, and also that they're not stuck in the situation that they were previously. And we have to set simple goals. Now, all of this can, in an ideal situation, this can happen in multiple sessions, but in India, follow up of families and patients is very, very difficult. So we have to keep that in mind, and we have to help people understand grief in this way. Please give me a second. I will just um, plug in the charger. And at this point, if anyone has any questions, please, you can put it in the chat box as well. Now, everything is not just sad, there's also happy outcomes. There are, you have, it's a very satisfying job, definitely. And the happy emotions that we come across as well are clarity, a very, very underrated outcome. But you have to again emphasize this with the families that you are counseling, that look, we have some clarity, we have answers to the questions that we did not know before. That then people feel hopeful when you tell them that, okay, there is a 25% risk of recurrence, which means that there is a 75% that you might have a healthy child. This change in perspective is very important for them. It is very important in decision making also, because um, a risk of 1 in 4 or a 25% risk, the individuals can make a decision if they want to undergo prenatal testing, or if it is a significant risk or not. And at least when they have some answers, they are very hopeful. People are relieved, people feel empowered to make decisions, and they also feel very determined to go through the medical odyssey. And finally, as I said, decision making becomes much better. So planning as well. Now, as genetic counselor, some hacks that I have collected over the months and years that I have been practicing. Um, First of all, you need to anticipate that you might have difficult conversations, that you might come across strong emotions in XYZ particular session. So you plan your interaction in advance. You can anticipate the questions that they are going to ask and keep those answers ready, and keep it in a way that it is very easy for them to understand. And we also have to pay attention to non-verbal communication, because a lot of these emotions like anxiety, fear, all of them can be caught by just non-verbal communication. And if we do recognize those, we need to address those. So we need to create bridges of communication. We need to tell them that you can trust us, because number one, we are there to help them, and number two, we have the clinical knowledge to help them as well. And finally, in the end, we can always we can tell them that this is, a solution oriented process, and the solution could mean anything. The solution could mean a diagnosis. The solution could mean the fact that you know you have a treatment, or solution could be just processing their feelings as well. And if it is very intense, as a genetic counselor, it is our job to refer them to a psychologist or someone who is an expert in this field. We are we can give them basic assistance, but if they need proper guidance and proper help, then we need to refer them as well. And we need to take feedback. We need to lead with open questions. And always, if there is an educated family, it is very healthy, I feel, to take feedback from them. It will only improve your therapeutic competence. And of course, if we need additional training, any other degrees, any courses that we can do, any training that we can take, it's amazing. That's the best thing. So, well, just as part of the hacks as well, if you think that it is getting out of the hand, then you need to pause and you need to reassess your session. This is again very linked to anger and frustration, because some verbal cues we can see is yelling, short responses, reluctance to talk, or even like tremors in the voice. Tremors in the voice could mean that they're about to cry or are really sad. um, and these are the verbal cues where their underlying emotions can be understood through their words or the tone of their voice.
Mhm.
Some non-verbal cues that we have seen before as well are furrowed brows, their crossed arms. Crossed arms usually means that they're just distancing themselves from the session. They would just love to be elsewhere and not in this situation and not in the session at all. Again, eye contact, clenched jaw means anxiety, to say simply, and crying, of course, is a very, very obvious emotion that, as genetic counselors, we need to understand how to deal with. And finally, once we have planned the session, we need to understand how we can help in a concise manner. So, in the end of the session, we can summarize everything, and we need to use negative words. We need to avoid using the negative words. For example, unfortunately, this has happened. Um, there is no cure at all, and things like that. How you can rephrase is, there is no treatment, but we can support the management
Mhm.
of the growth of your child, or in such a way. So we have to say that the treatment is unavailable, but management is. So we have to rephrase things that might not be so favorable for them. And finally, these are just a few abbreviations that I found from the research papers and books. Countertransference is a very, very important psychological aspect that both genetic counselors, psychologists, even doctors to some extent come across. And what countertransference means is that your subconscious emotions, behaviors, perspectives might come across and enter the counseling session, or it might come out as responses to another individual's story. I recently read a book called Genetic Counselling Principles and Perspectives by Patricia McCarthy Veach. You can read that book as well. It is really, really good for genetic counselors as it is written by a genetic counselor. Um, and she had mentioned that in a particular session, a genetic counselor and her patient were having a conversation. And the individual mentioned how her father is very unsupportive, how her father is very angry that she is sick, and things like that. Whereas she is the one, who should be getting the care and attention from him. This triggered a history for the genetic counselor, and she had to pause the session. And I think that is a really good way to go about it. And this is what countertransference means as well. It means that certain circumstances from your past life or from the experiences that you have had and have shaped you, you are triggered by certain things, and that comes off in your emotions and behaviors. And this, as genetic counselors, can cause a bias when we are counseling. So there are two types of countertransference. One is adaptive, the other is maladaptive. Adaptive is when you have recognized that there is this trigger, and you need to keep that in mind, and you need to distance yourself and not take things personally when a similar thing is happening in the life of your patients or their family. Maladaptive, on the other hand, is when you are not ready and not prepared, and the trigger, when it does happen, you react to it instead of responding to it. So that is countertransference. And a lot of these things can be solved by just reflection. As genetic counselors, um, we need to understand that we are very privileged. We have the knowledge. We also have a healthy life. We are able to provide care to other people who are sick or who need a diagnosis. So there are a few questions again given in the same book that I mentioned previously. You can go through those and reflect on how you reflect, in the sense, build your value system and your principle system on how you want to counsel, how involved you want to be in the families that you counsel. And that means you would become an empath. And we all know what an empath means. We come across it in our day-to-day lives, and it is a noble work that we are doing. So we have to be very sensitive to the families and also sensitive to ourselves. This is a case example that I had kept ready, but in case there are any questions, we can skip this. Seeing none, I will just go through with the case. So the case is that this is our proband, and she was diagnosed with Huntington disease at 45 years age, and she had a significant family history. All those colored in blue. I'm sorry you cannot read, but it's just that it was a really huge family. All those in blue. They also had Huntington disease, but we cannot mark that since they were not tested. Only she is tested, and there are a lot of genetic um, pointers can be understood by Huntington. Number one being anticipation. So I think in the third generation, from the proband, her grandfather was diagnosed at about 70 years, her mother was diagnosed at 60 years, and she is diagnosed by 45 years. So anticipation means that the severity increases and the age of onset decreases when you move from one generation to the other. So significant family history of Huntington disease, although they were not all genetically tested. The symptoms were very similar. Uh, our proband is definitely affected with Huntington disease. It is an autosomal dominant disorder, and it is also a triple repeat disorder. So there are dynamic mutations that are involved. Now, the story of this case is such that the family had gone many years back to to a genetic counselor. They underwent testing. They knew it was Huntington disease, but because the proband did not want to know her disorder and she just wanted to suppress everything, they had burnt all their records. So there were no past records, no MRI, um, no history that was taken about the other family members as well. And because of all this discord, there was um, there was a lot of barriers between the family members as well. So when we did do the testing, we gave her the option of cascade testing as well, but they straight off said that they will not share it with the rest of the family members, even if it will help them. So first of all, the difficult part of this counseling or this interaction was there were too many family members who had come for the counseling. There were at least 7 members sitting right in front of me, and each one wanted to give
Their
and
feedback.
contribute to the session because I was taking the family history, and it was just very tough. So in this situation, what we can do as a counselor is to take control of the situation. Remember, you are in charge, so you can tell them that the proband and one other family member can stay, the rest will have to wait outside. Then the second difficult part was the lack of documents. So to ask all the questions and them replying just by memory was difficult. But you have to keep asking open-ended questions and explore further. This might also lead to frustration on their end because you're taking a lot of time, but you need to emphasize that this will help them and it will help us make a provisional diagnosis. Then this discord between family members, we had to highlight how it could be helpful for others as well, and again for cascade testing and a lot of that. Now these people, this family had only come for testing because I think one of her sons had sorry, this 35-year-old male had a child. So he wanted to know if this could pass to his daughter, since his father had also passed away with symptoms that looked similar to his aunt. So he had brought her for testing, and she had a lot of stigma related to testing. She was not happy to get tested. Um, so she was also very angry. She did not want to give her blood for testing. And again, that is where you have to manage that reaction and help her understand how it is important, because so many family members have passed, and this in the second generation all individuals are affected. So you have to tell her how much she will be helping in the diagnosis. And so with that, I have finished my session. It was really long and I did not want to just be talking for this long, but I hope you have a few things to take back home today. And if you have any questions, I will be happy to answer those.
Thank you so much, Khyati. I don't think so it was long. I think it was quite apt. And
Okay.
the information was really well executed as well and delivered. So thank you for doing that. And I, personally speaking, I took a lot, not just some things, but I took a lot of psychology as well as counseling skills just by theoretically listening to you. Um, so yeah, and I was correlating to few of the things. So yeah, it's amazing to know that all the genetic counselors throughout the world, I think we are facing similar issues. So yeah,
All right, great. Thank you so much for your feedback, and I'm really, really happy that you're getting to take some things home.
yes. If anybody else has any question here, we can come forward and put it forward, or you can share your experience as well. We'll be happy to learn from it.
Uh, Hi, this is Shelley. Can you hear me?
Yes,
Hi,
hi.
Shelly.
So, Kathy, first of all, I really love the way you presented and the way you came up with those patient and counselor cues that they have and how you will have to, answer them. That presentation was something that I really, really, loved. And majority of the times, we genetic counselors from the time we start our career and, today what we are always taught of how to, take up the counseling. How do you talk about a disease? How do you talk about an inheritance? But we don't learn how to deal with psychological aspects of a patient that comes with experience. And today you presenting that, it is like an add-on for all of us.
Thank you. Thank you so much. Thank you for saying
That
that,
is
Shelly.
really I mean, you wanted us to take home something, and this is the take-home message for us that how important the psychological things are for when we are handling patients with genetic diseases. So I really enjoyed the session. Thank you so much.
Thank you, Shelly. Thank you. Are
Thank
you
you.
currently working or you're under training? You're a genetic counselor. What is your
I
background?
am I am a genetic counselor. I am working with KNH Clinic, and I am a consultant at AIG Hospital. So yes,
Okay.
with almost 3+ years of experience. Yes, good
Oh,
working now.
awesome. Awesome. So I will have lots to learn from you as well.
No, it's never like that. It's never like that. Trust me. But I enjoyed the session. Thank you for for hosting it, and thank you for presenting.
Thank you so much. Thank
Thank
you.
you.
Thank
Thank
you
you for
for
And
joining
joining.
happy
in.
weekend.
Thank you.
Okay. I think we can pause the session.
Okay. Wait. Don't speak. Cut. Wait. Cut. Let me. Let me. Pause. Let me. This record.